So what happens is because of the traction, because of the pull, if it's supposed to be like this, because of the pull they are arranged in such a manner that there is actually compaction and decrease within the space, decrease of the spaces.
Hello, Leon. Hello, Leon. Yes, I do. How are you?
Hello and welcome to Insight Ophthalmology. This is Dr. Amrit, welcoming you to another important lecture in glaucoma.
Guess who I'm drawing today?
The primary congenital glaucoma. The primary congenital glaucoma, as the name suggests, it's a primary condition. That means it is a problem in the trabecular meshwork and the anterior chamber angle, and there is no other ocular or systemic developmental anomalies. So this is very important. It is called primary because there is no ocular or systemic developmental anomalies. Only the developmental anomaly is present within the trabecular meshwork and the anterior chamber angle. It is congenital because it is
Hello,
seen
Yvette.
in kids and it can present at birth and leads to glaucoma. Therefore, it is primary congenital glaucoma. So, it is a genetically determined abnormality in the trabecular meshwork or in the anterior chamber angle, which will lead to increased intraocular pressure without other ocular or systemic developmental anomalies. Now, there are so many names of the primary congenital glaucoma. It was called the trabeculodystosis.
I'm good too,
which
Leon.
means that there is
How was your
dysgenesis,
day?
that is maldevelopment of the trabecular meshwork, or it is also referred to as the gonio-dysgenesis. Gonio means the angle, so dysgenesis is the maldevelopment, and it is also called the primary infantile glaucoma. Now, however, the term which is now very commonly used and also adapted by the international classification system for childhood glaucoma
How
is
was your day,
the
Leon?
primary congenital glaucoma. Now, the International Classification System for Childhood Glaucoma, it actually tells you the definition of the childhood glaucomas. Now, when we talk about the glaucomas in adult, it is very important that the optic nerve gets involved in adults and there is a corresponding visual field defect also present, and then the adult is said to have glaucoma. However, in childhood glaucomas, the proper or exact definition is irreversible or reversible damage to the whole eye. So you will see changes in the entire eye wall in childhood glaucomas, and that is the definition which is adapted by the International Classification System. So the primary congenital glaucoma is the most common type of primary childhood glaucoma.
Oh, okay.
And important
Your
thing is
cousin
that it is a
shoots
primary
content?
condition. That means there is no other systemic or ocular abnormality associated which is causing the glaucoma in these cases.
I'm thinking of doing
So the primary congenital glaucoma usually affects both
a
the
mini
eyes in
drawing
most of the
here
cases. So
and
it's a
then another one
bilateral
here.
disease. It is autosomal recessive and therefore the consanguinity actually increases the risk of a child developing the congenital glaucoma. Now there are 5 genes which are 5 gene loci which are actually identified with the occurrence of primary congenital glaucoma, and these are the GLC3A, 3B, 3C, 3D, and 3E. And the most common gene which is associated is the CYP1B1 gene, which is associated with the cytochrome C451B1. So remember this gene. This gene is very important, and the gene is actually associated with a lot of metabolic activities and migration of the neural crest cells, which occurs during the development of the trabecular meshwork and the angle. So, how does this primary congenital glaucoma develop? So, let us talk about the pathophysiology. So, basically, because of those genetic defects in the CYP1B1 gene, so we are having the problems in development of the cornea and the trabecular meshwork, and that is called the corneotrabecular dysgenesis.
I
Because
like
of
to
the
see your
corneotrabecular
videos.
dysgenesis, now we have an abnormal trabecular meshwork. Because of the abnormal trabecular meshwork, as we know that the trabecular meshwork is basically associated with the filtration of the aqueous. So whenever the trabecular meshwork is not adequate, there will not be good filtration of the aqueous humor in the eye. And because of that inadequate filtration of the aqueous humor, we will have increased pressure in the eyeball. Now, what happens in a child is that the child has very stretchable eyeballs. Okay, kids have very stretchable eyeballs. So what happens is that because of that more stretchability of the eye, which is seen in kids compared to adults, the eye is going to enlarge in response to the pressure rise in the eyeball. Now, because of that pressure rise, the eyeball will enlarge and even the cornea will get enlarged. Moreover, one more specific feature which is seen in children and is that they will develop corneal edema quite early. Okay. So histopathologically, what is seen in these kids is that the trabecular pillars are really thick compared to the normal individual. They are thick because of the deposition of abnormal collagen within them. So clinically, evidence has also shown that these trabecular pillars, not just are they too thick, but also there's a lot of traction on them. So what happens is traction is nothing but abnormal pull which is occurring on these trabecular pillars.
I said I'd like
Right?
to see your
So what happens
videos.
is because of the traction, because
You
of the
said
pull,
you
if it is supposed to
made
be like this, because of the pull, they are
certain videos
arranged
with
in
your
such a
cousin.
manner that there is actually
I like
compaction
to see
and
them.
decrease within the decrease of the spaces which are present within the trabecular meshwork. Okay, so because of the traction, there is compaction of the trabecular spaces, and because of that compaction and narrow spaces, the aqueous outflow will be impaired. Okay, so first thing is trabecular pillars are thick because of abnormal collagen deposition, and there is traction on the pillars in these cases, and because of which there is impairment of the aqueous outflow. And one more thing which is seen as high ciliary muscle insertion. So I will tell you what is meant by the high ciliary muscle insertion. So the most common hypothesis which is accepted for the development of the primary congenital glaucoma is the Anderson's hypothesis. Now, according to Anderson, he said that during the third trimester, what happens is the ciliary body, which is inserted anteriorly during the childbirth, okay, sorry, during the development of the embryo, the ciliary body
What's
and the
the
peripheral
channel?
iris are actually located quite anteriorly. But when the child reaches the third trimester of the pregnancy, okay, that means during the 7th month, 8th month, and the 9th month of pregnancy, what happens is that the ciliary body and the peripheral iris will now be pushed posteriorly and they will now be attached at their normal position. That means they are clearing off from the cornea and the sclera. So Anderson proposed that because of the
What's the
excessive
name of the
and the
YouTube channel?
premature accumulation of collagenous beams. So I told you that the trabecular beams are quite thick in these kids, and because of the excessive collagenous deposition in these trabecular beams, what will happen now is that for some reason this posterior sliding of the ciliary body and the peripheral iris will be inhibited. Now, as they do not slide posteriorly, what will happen now? They will be inserted quite anteriorly. So there will be anterior insertion of the iris root and the ciliary muscle. Now, since they are inserted anteriorly, it means that they are inserted quite anterior to the scleral spur, and they are also inserted near the trabecular meshwork, obstructing the normal flow of the aqueous through the trabecular meshwork, and sometimes they might even compress the Schlemm's canal. So because of that, so this is what I meant by the high ciliary muscle insertion or the anterior ciliary muscle insertion seen in
Oh,
this
okay.
primary
That's okay.
congenital glaucoma. Coming to the presentation of the primary congenital glaucoma, now there are various variants by which they can present. So one is the newborn onset. Newborn onset means that the primary congenital glaucoma will present or is present in about right at birth or 1 month of age. Infantile onset means from 1 year of age to 2 years, so 1 to 24 months. Okay, then the late onset or late recognized is usually after 2 years of age. And the fourth category is spontaneously arrested cases in which the IOP becomes normal and there will be actually half stride. That's all you're going to see on the clinical examination of such patients. So as you can see that the term infantile glaucoma does not suit all these presentations because the child can actually present as a newborn onset, as an infantile onset, or late onset also, or spontaneously arrested cases. Therefore, the term primary congenital glaucoma is more suitable rather than the infantile glaucoma. In these, the newborn onset is the most dangerous and is associated with the most poor prognosis. Now, what are the symptoms with which the child will present to you with the primary congenital glaucoma? Now, most of these symptoms are because of the raised IOP, and that raised IOP will then lead to corneal edema. The occurrence of corneal edema in a child with primary congenital glaucoma occurs quite early compared to the adults because the cornea in kids is not so well equipped by in getting rid of the excess fluid that gets deposited in the cornea because of the raised IOP. So the symptoms that we basically see are discomfort with light, which is called photophobia. Then the child will also have a contraction of the orbicularis or the spasm of the orbicularis, which is called blepharospasm. And then there also be excessive tearing, which is called epiphora. Now these three things they form the classic triad of glaucoma seen in kids, okay, of childhood glaucoma. So these are photophobia, blepharospasm, and tearing. So this is very important. Apart from that, the other symptoms or complaints which the parents might come to you can be the cloudy corneas and corneal scarring, and other thing is large eyes. Now, I already told you why they come with large eyes because in small kids or in newborns, the eyeball is quite stretchable. So, as the pressure within the eyeball increases, the eye also enlarges in size, and that is the reason why the parent sometimes might come to you complaining that their child has abnormally large eyes.
That's interesting. That's okay.
And definitely there will be corneal edema because of which the clarity and the transparency of the cornea will be lost and they will have cloudy corneas and scarring of the cornea.
I mean, you can always learn watching YouTube videos.
Coming to the clinical signs that we see in primary congenital glaucoma. The clinical signs can be large eyes, which is also called the bucthalmos. This is happening again because of the excessive stretchability of the ocular tissue seen in kids. Along with that, even the cornea will get enlarged, which is called the megalocornea or large cornea. Now, because of the excessive stretching, sometimes the descemet membrane, which is the inner layer of the cornea, will develop a break within it, and this break is usually oblique in orientation or horizontal in orientation. So you're going to see the stroma, and then on the either side of the stroma you're going to see this descemet tears, okay, bordering that stromal area, and such striae are called the Harp striae. So if you want to remember the orientation, you can remember it from the first letter of the Harp striae, that is H, and H here represents the horizontal striations. Apart from that, you can have corneal edema development, corneal scarring development, and because of the excessive eyeball size, you can have progressive myopia and astigmatism, which is very common in these kids. And because of the uncorrected refractive errors, and sometimes because of the excessive corneal edema, sensory deprivation, they can also develop amblyopia. So now let us answer some of the why questions. Why do you see corneal edema in these patients? So what is the link between IOP and corneal edema? In these patients, whenever the IOP rises beyond 30 to 40 mm of mercury, the endothelial cells will not be able to function properly and they cannot pump the excess fluid out from the cornea. Along with that, there will be excessive stretching, which we know is occurring in these kids, because of which we will have striae formation, Harp striae. Once a tear develops in the descemet membrane, the aqueous which is present in the aqueous humor can also seep into the cornea, leading to corneal edema. So, as you can see here, we can see this line, oblique line going on horizontally like this. This line is, these two lines actually represents a tear in the descemet membrane, and in between you have the stroma, and this is your Harp's striae. Now, the second question is, why do you see corneal enlargement? Now, to answer that, at birth, the diameter of cornea is about 9.5 to 10.5 millimeters, and then it increases to 10 to 11.5 millimeters by the age of 1. Now, if you see any diameter of the cornea which is greater than 12 millimeters before 1 year of age, okay, or before child's first birthday, or if there's any asymmetry between two eyes, or if the diameter of the cornea is greater than 13 mm of 13 mm at any age, then definitely you have to suspect glaucoma in such children. And the reason for corneal enlargement is again corneal stretching. The stretching can also occur in the other tissues of the ocular of the eye, And what happens is that the cornea stops enlarging at the age of 3 years. This is very important. That after 3 years, even if the pressure rises, the cornea will not enlarge further. However, the sclera continues to stretch up to an age of 10 years, and therefore the eyeball enlargement of the diphthalamus will continue to happen. The other sign which you see is optic nerve cupping, which is also occurring in these kids because of the stretching mechanism. Now, as we know, the cornea stretches, the sclera stretches, and as the sclera is stretching, there will be posterior bowing of the lamina cribrosa, and as the posterior bowing of the lamina cribrosa happens, the optic canal also stretches, because of which you will feel as if the neuroretinal rim has decreased thickness, and it will look as if there's optic nerve cupping. However, when the IOP is normalized, there can be a reversal of the cupping. So this is a very important feature of primary congenital glaucoma, that there is reversal of cupping. However, whenever there is in advanced glaucomas, whenever there is a retinal nerve fiber layer damage, okay, then the cupping will more likely be permanent. In older children, those with advanced glaucomas, cupping actually is occurring because of the neuroretinal rim tissue along with the stretchability. So these cases will not show any reversal of cupping. The first picture you can see there's corneal edema, and in second picture you can see here the cupping which is in primary congenital glaucoma. Coming to the diagnosis and what are investigations you do in such children who come with primary congenital glaucoma. The first measurement that we take is IOP.
Yeah, that's right.
IOP in kids is done with Perkins or McKay-Mark tonometer. In older children, we can use the Goldman's tonometer as well. Then corneal diameter should be measured. You can use the graticule function on the slit lamp. Anterior chamber depth, gonioscopy has to be done along with axial length measurement, and direct or indirect ophthalmoscopy to have a look at the optic nerve cupping. Cycloplegic diffraction must be done to rule out myopia and astigmatism. Coming to some findings on gonioscopy in infantile glaucoma or primary congenital glaucoma, the gonioscopy that we do has to be done under sedation or general anesthesia. And as I told you in my course on gonioscopy, you have to do direct gonioscopy using the Kepis or Hoskin-Barton or Swan-Jacobs lens. Now, however, the gonioscopy in infants is somewhat difficult, and the reason is that number one, that there will be marked corneal edema, which makes it very difficult for us to visualize the angle structure. Number two, there is not proper demarcation of the angle structure, because of which you will have an amorphous appearance of the angle. And third is identification of the posterior trabecular meshwork is also difficult because kids or infants, they do not have much pigmentation. And what are the angle characteristics that you see in the congenital glaucoma? Sorry, I wrote infantile.
Thank you, Leon.
Both can be used for the same disease. So the angles characteristics that you see, the angles will be.
I think this is Dohan I'm drawing.
Flatter iris configuration. The periphery of the iris will be thinner because of the maldevelopment of the iris as well. There will be higher irregular insertion of the iris, as I already explained you, and sometimes there will be a generalized sheen in the trabecular meshwork because of the thickened trabecular beams. So that's all for today. Thank you and have a nice day. Insight Ophthalmology. This is Dr. Amrit welcoming you to another important lecture. This is a basic lecture, and today we are studying the visual field defects in glaucoma. So what is meant by visual field? The visual field is defined as the area that is perceived while fixating on one central target. So when you fixate on one central target, the amount of the area that you see around that target is called as your visual field. Okay, so the tracker's analogy says that the visual field is an island of vision surrounded by a sea of darkness. So as you can see, this is like the hill of vision, and here is the point of fixation, and the visual acuity and the clarity is maximum at this point of fixation because it corresponds to the fovea. And then as you go in the periphery of the field of vision, the clarity will decrease. So this is what is known as the island of vision or the hill of vision surrounded by a sea of darkness. Now coming to the normal extent or the field of vision, it is very important. So if you see superiorly, the field extends up to the 50 degrees. Nasally, it is about 60 degrees. inferiorly it is about 70 degrees and temporally it is about 90 degrees. So if you can see, this is the point of fixation, okay, and this lady is able to see apart from the point of fixation an area around the point of fixation, and that is called the field of vision. And as you can see, the field of vision is maximum in the temporal area, that is about 90 degrees. So what is meant by the blind spot? Now we should know, first important point that you should know is that the normal blind spot is about 15 degrees temporal to the fixation, and the measurements of the blind spot is 6 degrees in the width and 8 degrees in the height. So let me explain it to you what is meant by the blind spot. The blind spot corresponds to basically the optic nerve inside the eye. Now, as we know that this is the retina, and the information from the retina is being carried by the optic nerve. Now, the optic nerve is a place where actually we do not have proper retina. It is like a vacuum, or it is like an empty space. So therefore, the area of the retina corresponding to the optic nerve does not does not contribute to any visual field, or does not contribute to vision. And since that area of the retina is not corresponding to the visual field, that is why it is called a blind spot. Okay. Now, in our normal eyes, if you see, this is the nose. Okay, and you can see the optic nerves are actually present towards the nose in the nasal part, and the macula is always situated away from the nose. That means in the temporal area, and that is the reason why the blind spot is present in the visual field temporally. Okay, the visual fields are always opposite to what we see in the retina. So the nasal retina corresponds to the temporal visual field, the temporal retina corresponds to the nasal visual fields, and therefore, since the optic nerve is located in the nasal part of the retina, the blind spot is located in the temporal part of the retina, and the blind spot is about 15 degrees from this point of fixation, and as I already told you, the width is 6 degrees and the height is about 8 degrees. Now coming to certain important terminologies that we must all know before going to the visual field effects in glaucoma. So number one is what is meant by scotoma. A scotoma is basically an area of reduced sensitivity surrounded by a more sensitive area or a normal area. So if you see, this is a blind spot also is a scotomatous area. Now if you can see this area marked in black color, it is surrounded by the normal retina or the normal visual field, and therefore this area is called a scotoma. Right? So scotoma is an abnormal area surrounded by a more sensitive or a normal area. However, this does not apply to the depression. Depression means there is an area of reduced sensitivity, but that area also is surrounded by an abnormal area which does not have the sensitivity closer to the normal retina. So as you can see, this black area I have drawn, so this is a generalized field depression, and you can see surrounding that also there's a gray area which is also abnormal. Okay, so that is called depression. So that is very important, the difference between scotoma and depression. So scotoma is more well defined compared to depression. Coming to isopter. Isopter is nothing but when we actually measure the visual fields, we are measuring the sensitivity of various points on the retina, okay, in decibels. So if you find sensitivities like this, okay, and say this 32 decibels here, and 32 decibels here, and if it is 32 decibels in all these points, and we join these points, what we get is an isopter. So isopter is nothing but it's a threshold line which joins the points of equal sensitivity on the visual field chart. So this could be one isopter, this is another isopter, and this is another isopter. The meaning of isopter is that every point which is going to lie on this circle they're going to have equal retinal sensitivities. Okay. Then of course I told you what is meant by fixation. Fixation is a part of the visual field which is corresponding to the fovea centralis. So this part is the fixation point, and from here is your blind spot which is located 15 degrees temporal to the point of fixation. Now this picture is very important because here I want to tell you what is meant by the central field, what is meant by peripheral field, and what is meant by the germs area. Now, the portion of the visual field which is present within 30 degrees of fixation. That means this is the point of fixation, and if you can see these circles which are drawn from this point of fixation, they are drawn at various degrees. So this is 10 degrees, 20 degrees and 30 degrees. Now if you consider the entire area which is present within this 30-degree circle, this is called the central field of vision. And the entire area which is present outside this 30 degrees of field of vision, that is represented as the peripheral field of vision. Now you may ask, then what is meant by the germs area? Now the germs area, however, is an area within the central field of vision which is present within 25 degrees of fixation. So this is fixation, this is 20, this is 30. So in between this, there will be a 25-degree circle if you draw, and that area between this 25-degree circle is called the germs area. It goes behind the name of the scientist who discovered a lot of scotoma occurring in glaucoma patients within this 25-degree circle, and therefore it is called the germs area. Now, before you understand the field effect in glaucoma, it is very important to understand the distribution of fibers in the retina. So this diagram is going to help us understand how the various nerve fibers are entering the optic disc. They don't enter in a very simple way, however, they follow a specific pattern. So let us see. The nasal retina, as you can see, the nasal retina that is present on this side of the optic disc, okay, they are going to enter as radiating fibers from the nasal side. So the ones coming from the superior, they are going to form the superior radial fibers, and the ones coming from the inferior, they are going to form the inferior radial fibers, right? So the nasal retina is going to come to the optic disc in the form of superior and inferior radiating fibers, and they're going to occupy the nasal part of the optic disc. The macular area, however, is going to go straight ahead into the optic nerve, and it is going to form what is known as the papillomacular bundle, represented here as PMB. Then we have the temporal retina. The temporal retinal fibers, they actually forming an arch. They form an arch over this papillomacular bundle and over the macular areas, and this is how they are going to insert inside the superior temporal part and the inferior temporal part of the optic disc. So the fibers which are entering into the superior temporal part here, they are called the superior arcuate fibers, and the ones which are inserting into the inferior part of the disc, they are called the inferior arcuate fibers. Now, an important point about these arcuate fibers is that, as you can see, these arcuate fibers, they're never crossing.
Hello guys, welcome to my channel.
Okay, they respect a midline, they respect a horizontal
I'm drawing
boundary, and that horizontal boundary is called the
Gohan,
horizontal graphite.
son
So I
of
hope that is
Goku.
clear regarding the distribution of fibers in the retina. So as I told you, here if this is the optic disc considered of the left eye, this is the macular area. The macular area here, okay, is the most temporal part of the disc, is receiving the macular fibers and receiving the papillomacular bundle. Now the superior temporal part and the inferior temporal part, they are receiving basically the arcuate fibers, okay, and we know that the
Hope you
arcuate
like my
fibers
art.
are coming from the temporal retina, right? So this is the temporal retina. They are coming as the superior and the inferior arcuate fibers, and they are occupying the superior temporal and the inferior temporal parts of the optic disc. Then we have the radiating fibers. Radiating fibers are coming from
If you are just joining, this is
and they are
Maqfoli
coming
Art.
into the superior nasal and the inferior nasal part of the disc. And these nasal fibers will not respect the horizontal raphe. However, the temporal fibers are definitely going to respect this horizontal
I hope you
raphe.
guys
And
subscribe
what
to
do I
my
mean by
channel.
respecting horizontal raphe is that they will not cross beyond this. The superior fibers are not going to go into the inferior zone, and the inferior fibers are not going to go into the superior zone. So that is very, very important. Now, how are these distributed inside the optic nerve? Now, this optic nerve, if you see, the deeper fibers are the more peripheral fibers. That means the fibers which are coming more anteriorly, they are present the most deeper inside the retina, and however, as they enter the optic nerve, they are going to be the most superficial. However, the fibers which are coming more posteriorly towards fibers near the optic disc, okay, they are going to be more superficial inside the retina, okay, inside the retina, and when they go into the optic nerve, they are going to be more central. So you can remember it as the fibers which are coming from the anterior retina, they are deeper in the retina and they are superficial, however, in the optic nerve. However, the fibers which are closer to the optic disc, they will be superficial in the retina, but they will be deeper inside the optic nerve. So that is very important. Now the question arises, which all of us are waiting for, is which fibers are the most sensitive to glaucomatous damage? And the answer here is the arcuate nerve fibers. They are the most sensitive to glaucomatous damage, and they stop at the horizontal raphe. Now the question is, why are the arcuate fibers more susceptible, or why are they involved earlier? Okay. So here again I would like to remind you that we're talking about the superior arcade fibers and the inferior arcade fibers, and they are the ones which are more commonly affected and more susceptible. The reason is, number one reason is the watershed theory. The watershed theory says that the superior and the inferior poles of the optic nerve, they contribute to what is called as the watershed areas. A watershed area is a zone which is supplied by two blood supply, which has dual blood supply. So the thing about dual blood supply is that the distal part of these blood supply will be very, very thinner arteries. So whenever there is hypoperfusion, this area, this watershed zone will be actually compromised because of decreased blood supply in these areas, right? So the superior and the inferior poles of the optic nerve, they form the watershed areas, and that is the reason why they are more susceptible to get involved in glaucoma. Now, as you can see, this is actually a picture taken from a journal in which they ligated or obliterated the lateral posterior ciliary artery. So you can see there is no filling, or there's a filling defect on FFA here. So this picture actually shows you that the medial PCA is supplying the medial part of the optic nerve and the medial retina. Okay, and the temporal part of the optic nerve is entirely supplied by the lateral part of the optic nerve is entirely supplied by the lateral posterior ciliary artery. So definitely the superior and the inferior pole, or the superior temporal or the inferior temporal folds, they form the watershed areas, and therefore they are involved more in glaucoma. The second theory, which tells you that why the superior temporal and the inferior temporal poles are affected more, is the porous theory or the pores theory. The pores theory says that when the electron microscopy or the ultrastructural examination was done, you can see that the pores in the lamina fibrosa, which are present in the superior temporal and the inferior temporal region, they're much bigger compared to the pores which are present in the other parts, right? So what happens is, if the pores are bigger, the extracellular matrix, or the external support to the nerve fibers which are going to pass through this bigger pores, will be less. So because they do not have that excessive support or good framework because of the larger pores, whenever the pressure rises, the compression of these optic nerve fibers which are passing through these larger pores will be greater, and that is the reason the damage will be greater at the pores. Now, after you know which fibers are more susceptible, the next question is which fibers are more resistant. Okay, and here the answer is the macular fibers are the more resistant. So now I told you that the arcade fibers are affected the most, and in that it is the inferior arcade fibers which are more affected, and over here in the optic nerve we have the inferior vulnerability zone as well, and that is the reason why the superior visual field defect is more common. Okay, so the arcade fibers are more affected, and in those arcade fibers as well, it is the inferior arcade fibers which are more affected, and therefore there is superior visual field defect. Now, in second in number is the radiating fibers, that is the nasal fibers, and the last to be affected is the macular fibers. So that is why in glaucoma the central field is preserved till the end. Now let us talk about the glaucomatous field defects proper, coming to the proper topic of the day. So The glaucomatous field effects are basically two types: the non-specific field effects and the specific field effects. Under the specific glaucomatous field effects, which are seen only in glaucoma, there will be certain early field effects, and there will be late specific field effects and advanced specific field effects. So let us now first talk about the early non-specific field effects. Now, the early non-specific field effects can be classified into the isopter contraction. So, isopter contraction is nothing but, as I told you, that the areas of retinal sensitivity can be marked by an isopter, right? The areas of equal retinal sensitivity. So, this was what was done basically in the kinetic perimetry. So, what happens is in glaucoma, we know that there is a constriction of the peripheral fields and also the central visual fields. So as the constriction occurs, these isopters are also going to constrict, right? So this is called as the isopter contraction, in which there is a mild constriction of the central or the peripheral visual field. The second effect that we see is a bearing of the blind spot. Bearing of blind spot is nothing but if you have a blind spot like this and we have this isopter like this, sometimes there will be a localized constriction of the isopter in such a way that the blind spot will be excluded from the field of vision. So that is called a bearing of the blind spot. It is because of the exclusion of the blind spot from the central field due to the inward curve of the outer boundary of the 30-degree central field, right? So the blind spot gets excluded. And the third one is the enlargement of the blind spot, that is depression of the peripapillary retinal sensitivity. Okay, so what happens if this is a blind spot? I already told you that the blind spot is 6 degrees and 8 degrees in the height, right? So sometimes because of the peripapillary atrophy that is seen in glaucoma, but mind you, it is seen in many more conditions like myopia as well, you can see enlargement of the blind spot area on the visual field. Now all these things are not specific to glaucoma, and they can be seen in various other ophthalmic conditions as well, and therefore they are called the early non-specific defects. Now don't worry if you don't understand this, I will explain it to you now. So to explain to you what is meant by isopter contraction, I want you to remember this slide in which I told you what is meant by the central field, which is within 30 degrees, and Jerom's area, which is 25 degrees. Anything outside 30 degrees is the peripheral visual field. Now the isopter contraction is nothing but these isopters, that is 30 degrees, might come to the location of 20, right? So if the field is getting constricted like this, okay, this is called the isopter contraction, right? Now, however, sometimes there will be a localized constriction in which the field is going to come like this, localized constricted in such a way that the central field, instead of going like this, which was its normal position, it has now excluded, it has now turned inwards, excluding this blind spot. Okay, so this is called bearing of the blind spot. Bearing of blind spot is not such a specific feature of glaucoma because it can also occur in physiological conditions, and the reason is that the superior retina is more sensitive compared to the inferior retina, right? So sometimes if you take the measurements in such a way, considering this fact, the bearing of blind spot might also be seen in normal individuals. So therefore it's a very non-specific finding. Then sometimes, as I told you, that the blind spot measurements, you should remember, it is 15 degrees temporal with the fixation and measures 6 degrees wide and 8 degrees in height. And just look at this blind spot. It is quite a bigger blind spot, and this is called enlargement of the blind spot. Again, enlargement of blind spot can occur in so many conditions, and therefore it is not a very specific sign of glaucoma. However, if the blind spot gets enlarged in a vertical direction like this, the blind spot is like this, and then it is progressing in an arcuate fashion, then definitely it is more significant, and that I'll tell you what is it called. Now let us talk about some early significant changes which are specific to glaucoma. The first one is a paracentral scotoma. As the name suggests, it is located in a paracentral location, that means very near to the fixation point within the 10 degrees isopter, and usually it is a wing-shaped structure. Then we have the sedal scotoma. Sedal scotoma is nothing but sometimes you have a paracentral scotoma like this, and then obviously at 15 degrees we
Hello
have
guys,
what we
welcome
have.
to
We
my
have the
channel.
blind
Thank
spot.
you for
So
watching.
blind spot and this paracentral scotoma
Yes,
might
that's
actually
Gohan.
mix together, and they will form a sickle-shaped scotoma, and that sickle-shaped scotoma is called the sickle-shaped scotoma. Now there's
If you're
another word
watching,
which is
kindly
given to
subscribe to
this,
my
and
channel.
that is called the Deringer's scotoma. Now I want you to comment in the comment section as to why is it called a Deringer's scotoma. So let me know in the comment section.
Thank you
The
for
third
watching and
early
thank you for the
significant type which is
subscriptions.
specific to glaucoma is a nasal step. So nasal step is a small area of depression. It could either be above or below the horizontal raphe, but it is present in the nasal visual field. Now the reason it is called nasal is because it is present in the nasal visual field. Now important thing what I want you to remember is that the paracentral scotoma and the sedal scotoma, they both are central scotomas, whereas the nasal step is actually a peripheral visual field defect.
I'm
Now
going to
this
try
picture
to
over
draw this
here
one very
shows
quick.
you a scotoma which is present, as you can see, it is
So I'm
present
going to
about 10
restart the
to
live.
10 to 20 degrees. Okay, so quite near to the 10 degrees isopter, and
So
this is a
kindly
paracentral
subscribe to my
scotoma.
channel if you're
In the
watching.
picture here, you can see the blind spot, and here one
I'll be
scotoma. So you can
restarting
see
the
the sickle
live
cell
in a
scotoma. This
few
is the sedal
seconds.
scotoma, and you can imagine it to be developing by the joining of this blind spot with the paracentral scotoma. Then this picture over here shows you an area of depression here. So this is the blind spot. You know that the blind spot is located temporally, and therefore the opposite part is the nasal part. So this part which is seen nasally, the nasal depressed area seen in the periphery, is actually the nasal stem.
Alright,
Now have a look at
thank
this
you for
picture. Here
subscribing
you
to
can
my
see the
channel.
blind spot. The blind spot is looking abnormal. The height of the blind spot is too big.